front of me when I have a newborn baby. Then hold the baby upside down, slap the back. Maybe you must speak a new language. Okay, then the other options. Let's see the next question. So you are ventilating as asphyxiated postdate female neonate, but realize that ventilation is not yielding appropriate chest rise, and the baby is getting bradycardia. What is the first thing we do to ensure ventilation? Now, the first question was mathematics. This one is now further maths. So if you know, we'll come back to this, right? Fine. So let's. Every delivery, if you have 100 babies at our home, 90% will not require resuscitation, right? So then why are we here, right? If 90% of babies resuscitation, why are we here? The 10%, if you look at the world's population, you'll realize that we have a lot to do to keep those 10% alive. Now, 10% will require resuscitation, and you can see those 10% fall within the list that we have there. Now, of these, 1% will require extensive neonatal resuscitation. And it is important that by the time we are done here, we would have run through all of them, right? So who are those that fall within this 10%? Any baby who is preterm, meconium stained amniotic fluid, for us, will have to act. Let's move in first. Fetal distress, congenital malformations, multiple pregnancy, malpresentation, and any maternal medical condition is a risk. You have to start something. So we talked about preparation. How do you prepare for resuscitation? There are key questions I would ask, and I want all of us to bear in mind that we'll have to ask when we have to resuscitate newborn babies. What is the gestational age? Remember we said in the previous slide, the baby is preterm, right? So gestational age is important. Is the light bulb clear? Remember we talked about meconium stained amniotic fluid, right? Good. Now, the number of babies. Again, remember we talked about multiple births. So if you have multiple births, you will need to be prepared. Do we have any maternal medical risk factors? We talked about preeclampsia, maternal diabetes, and all that. Now, who are the personnel you need? You need at least one person who is skilled. So I'm happy that with the number we have here, we will contribute a lot to significant reduction in deaths because of failed resuscitation. So you need at least one person. By the time you are getting extensive resuscitation, you need two anyway. But if the first is done well, you just need one person. Now, it's a team because one person will do, but we have it. The briefing, the roles, effective communications needed. Now, we have a checklist of equipment that we must have before we say, oh, we are set. In addition to having a timer, a clock, and umbilical cord clamps, you will need all this. As it is, or as adaptable to your practice. So we have a radiant warmer in our theater, in our labor room, in our newborn unit. So we have that privilege to have that. And we get it preheated before the baby is born. We have towels, blankets, hats for the babies. Now we need to be able to clear the airway, syringe, pulp syringe. Now, if you have a suction catheter, maybe you may be learning this for the first time, that the suction pressure for an adult is different from that of pediatrics. The suction pressure for a 2-year-old is different from that of a neonate. So you set this. So WHO has said it is between 50 to 100 millimeters of mercury. But expert opinion put it between 60 to 100. But we will commonly want, in practice, 80 to 100. We are not above the upper limit, but we get effective suctioning. We need stethoscope, we need a positive pressure ventilation device. You see, this is a friend of mine. We've been moving around together, and we'll use this to learn the first 2 nursery rhymes you will learn here. Good. Now, we need equipment for oxygenation, intubation, and medications. This is for the last 2 you're actually getting extensive at this point. Good. Now let's take a deep breath because we are launching into the algorithms for neonatal resuscitation. I will not bore you with the details of algorithm number 1. It is helping babies breathe algorithm, used commonly, basically in primary healthcare settings. But it's important to know at this point that There is a critical need to commence breathing for all babies within the first minute of life, which is the golden minute. It is not a time to take care of skin beauty and apply olive oil, right? So the first minute of life, that baby should be breathing. You can see the algorithm. It will be given to you in the slides we have. But we'll discuss a more extensive one as we make progress. So algorithm number 2. So I want us to pay attention and just so that we flow together, because we'll have like 8 stations where we will demonstrate what we are doing here. In the steps, this is neonatal resuscitation program steps for people like me and you at the level we are operating. We have, I'll tell you a lot of things in 3s. When you have to resuscitate the baby, you have 3 steps, 3 things to follow. You ask, are we together? I said you do what? The next one you act. I said you do what? And the last one you assess. Yeah, A raised to power 3. So you ask, you act, and you assess. Now, the acting is what we have. So in the acting, ABC, let's take it. Airway, breathing, circulation. That's what you are going to act, right? So I'm actually going to finish resuscitation discussion on this slide. Then we will just walk up through with the remaining time we have. So you ask critical questions. Now the questions you ask from the beginning, I code it as TCT. Is the baby term? Yes, no. Is the baby crying? Yes, no. Is the tone good? Yes, no. Now, if the answer to these 3 questions, we have all of them, yes, that baby falls under the 90% that will not require resuscitation. Give the mother to commence exclusive breastfeeding. Right? Good. So, but if you have no to any of these 3 questions, you activate resuscitation process. So I said the first thing you act, right? Now you ask. So you ask, and there is one no to the 3 questions. The next thing is what? You act. So the next thing is airway. The first step in acting is airway. Now when we say airway, our mind goes to the throat, and no. You take the baby to the preheated radiant warmer. You clean up the baby very quickly, exchange the linen that was wet, position the head in neutral position. There are 3 landmarks for neutral position, which I will display in the slides that will follow. Then you suction the airway lightly. You could use a bulb syringe, you can use a penguin suction, or you use the suction machine. Now, if you're using suction machine, you would have set it not more than 100 millimeters of mercury. You don't go 200 and suction the brain out through the mouth, right? Good. So you have acted. I say you ask TCT, the answer to one of them, or 2 or 3, no. So you act, position the baby in the neutral position, under radiant warmer, clean, take care of the airway, you have acted. Then you assess, is the baby better? The next step is breathing, right? Now when we say breathing, there is a problem with respiratory distress. There are just 2 types. It's either the work of breathing is high, the baby is breathing spontaneously quite well, or the work of breathing is high. So the baby is using excess efforts, right? There's subcostal recession, there's suprasternal recession, there's head nodding, there's flaring of ala nasa. You find that occurring, you just give oxygen, because that baby is breathing spontaneously. But better still, you give CPAP. We have an automated CPAP machine with digital screen directly behind us. One of our experts will take you through it there. Now, but if the baby is gasping, or, never mind, you see all this in the slide, but let's talk first. If the baby is gasping or apneic, you start bag and mask ventilation. So you do not ventilate a baby who is spontaneously breathing but having labor breathing. No. It's a baby who did not cry, so is not breathing, or is too quiet, is gasping. Now, our first nursery rhyme, are we together? So when you have to ventilate that baby, it follows a rhythm. And this is it. You compress. Breathe, 2, 3. Can we go together? Breathe, 2, 3. Breathe, 2, 3. Let's go. Want to go? Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. That is the rhythm. You know why? The respiratory rate of a newborn baby is 60 breaths per minute. Now, I've been in some places where you find, this baby will not die in my shift. Baby, breathe. Breathe, you will not die in my shift. It's not my portion. It's not my portion. That will not happen after this symposium, right? So what happens once you go? Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. Yes. So you do that, and you see, we've done airway and breathing, and all I have said so far is within the first golden minute of life. So let me go it very fast so that we know that we can do it in 1 minute. Baby is received, TCT, tone, cry, term, no, I collect the baby, place on the radiant warmer, clean up the baby, exchange the linen, position in neutral position, suction the airway, I check for breathing. Is the baby having apnea or gasping? I do what? Breathe, 2, 3. Breathe, 2, 3. That's enough in 1 minute, true or false? You can do that, then clap for yourselves now. So that's all. Good? So that's B. Now, after you've done B, I am actually discussing that algorithm, and it's on your booklet, right? So after B, the next thing is circulation. The algorithm puts it circulation. My own Peter version, in my head is compression. But when I compress, circulation will be established. So to check for circulation, again, there are 3 questions. What is the heart rate? Is it less than 100? Can you look up? Is it less than 100? Is it less than 60? Is it less than 60? Are you confused? First, is it less than 100? Second, is it less than 60? Third, is it less than 60? Very, very important. We are not confused here. So quickly, if you have facilities for ECG leads, they are placed on the baby as you are resuscitating the baby, you check the heart rate. Or if you do not, I would prefer that you use your hand to palpate the umbilical stump. So you count for the pulsations in 6 seconds. So can we work together? I want to do one little calculation. I palpate the umbilical stump and I get 7 pulsations in 6 minutes. So I multiply 7 by 10. What is the heart rate? So that's below 100, right? Then something is wrong. So I act. So is it below 100? Yes. So I act. That is when I would have to recheck what I did, right? There is a code called Mr. Soper, which we will see in the slide that follow. So I will reposition the head, check the alignment of my hand on the mouthpiece. Now, even though it will be discussed practically, look up and see how I'm going to do it. So I form a C with my thumb and the first finger. Then the middle finger goes on the jaw. You try to avoid the throat. When we do practical sessions, a lot of people will be occluding the throat of the baby to cause asphyxia post-delivery. Don't give asphyxia to our mannequins, right? So don't asphyxiate your baby. So these 2 fingers go around, hold it firmly, and then this goes to the jaw. Your ring finger, protect the ring. The person, where is the MC that married somebody that is fat? Protect the ring finger away, right? So that you hold. Now, there is another song we will learn. The first one was what? That is it too, right? Or you are not going slow, you go with good speed, right? Now, the next one is this. When we realize that we have positioned the suction, we've done all we're supposed to do, clear the airway, additional airway, we now check again, count the pulse rate. Now, I have palpated, and I counted 5 pulsations in 6 minutes. So I multiply by 10. How many do I get? So that's below the first 60, right? Good. So that is only when I will compress the chest. You only compress the chest of a baby who you have confirmed that the heart rate is below 60. So the next song is this. I compress 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. Are we together? Let's go. 1 and 2 and 3 and 1 and 2 and 3 and 1 and 2 and 3 and. Do you know why? The ratio is 3:1. So the child, the heart rate is 3 times the respiratory rate of the baby. Now I have seen some people somewhere in one part of Nigeria. So the nurse is pressing, not in my shift, oh God, not in my shift. And the other person is backing. So there's a dysrhythmia of the lack of coordination between compression and it's not how hard you do it, it's how well. Do we get it? So you do that, that ratio of 3 is to 1. Now, when that is done for 1 minute, you palpate again, and the pulse rate is, you now counted 4 in 6 minutes. 4 times 10 is what? It's below the second 60, right? At that point, you have to give adrenaline. Are we okay? Good, fine. We'll stop here and then progress. So enough of the gist. Let's make progress on the slides now. Is it clear? So you learned 2 songs today. 1 and 2 and 3 and 1 and 2 and 3 and. So when do you use breathe 2, 3? And when do you use 1 and 2 and 3? When do you use breathe 2, 3? Who can tell us? You collect my tea break. I was fasting because I needed to give stuff. So if you get it right, I just give you my own. Okay, what? Okay, fine.
What do you when you're ventilated? That's when you're giving oxygen. When you have to
Wait. Which one are you saying? Okay. Breathe 2, 3. And come again. Breathe 2, 3 is when? Okay, who else? Critical. Okay, the person behind. Breathe 2, 3. When? Yes, when the baby is apneic or gasping, right? When do you do 1 and 2 and 3 and breathe? Fine. Do you have to do breathe 2, 3 for a baby who is in respiratory distress, who is breathing spontaneously but is using a lot of effort? Fine, so you can take over the lecture from here. Good. Okay, so fine, with the remaining few minutes we have, I will run through the other steps. So this is what I talked about in the airway. Do I need to talk about this slide again? This is all about the airway, right? Good. So you suction the airways. You suction what you see. I have seen where some very good people put the entire length of NG2 down the throat of the baby. They are stimulating the vagus nerve and want to cause bradycardia for me. No, you suction only what you see and stimulate gently. Stimulation is you are cleaning the body. So this is the neutral position. So we have 3 landmarks. The first one is the glabella up here and the chin is horizontal alignment. Right? Please note this. Now the neck is wide open so that the chin is almost at right angle, vertically upwards, not becoming an obtuse angle that is hyper-extended, not an acute angle which is flexed. Now the third one is the external auditory meatus and the suprasternal notch. They are horizontally aligned. Let me ask a question. Can you get a baby in neutral position and there is no pillow, nothing to support the head at all? I get the baby and just place on the radiant warmer, and is it possible? Is it possible that I just put a headrest and I am able to get neutral position? We are not. My audience has gone to sleep. You want to sing 1 and 2 and breathe? Okay, so there must be something under the shoulder and under the head. Except you are actually doing the support with your hands. So you can actually do it with your hands yourself. But that the baby is left on its own, on a flat surface, it can never be neutral position. Let's bear that in mind. Okay, so breathing, we've talked about this. You say when the baby is apneic, gasping, bradycardic. Are we together? Yeah, so this one you compress the bag and mask at this rhythm of breathe 2, 3, breathe 2, 3, right? You watch for chest rise and that the heart rate does not drop. The next is, this is the position, I described this, right? Look at the third picture, that is it. So the first, the neck is, there's a chin lift here, and then your position, I have described that with the ample bag that I have here. And this must be done within the golden. So circulation, you say you palpate the pulse, and then you check for interventions. So less than 60, that is when you commence compression at the rate of 1 and 2 and 3 and good. Now the compression is 1/3 of the anteroposterior chest diameter. Please do not fracture the ribs of the baby. You give us more trouble. But if it fractures, bring to us. We'll fix it. Right? So effective. So what if ventilation does not yield appropriate chest rise and heart rate is not improving? Now the definition of effective ventilation is that the chest would rise and drop with every time you do your ambu bagging, and the heart rate would increase. Now this is it. We have these to follow. So bear in mind the second question of the quiz that we discussed at the onset. Now it follows this acronym of Mr. Soper. In the event the heart rate is not improving, the child is not having chest rise, you adjust the mask. So you reapply the mask using the two-hand technique as I've explained. One hand holding it and you apply. Then reposition the airway. When you do the first two, you reassess. You bag and you reassess, right? You should have improvement. If not, you suction the mouth and the nose. So you suction mouth first before suctioning the nostrils, not the other way around. You open the mouth and bag. Then you can increase the pressure of your compression. And then finally, you place an endotracheal tube or a laryngeal mask airway. We'll have a station to demonstrate intubation in this, our practical session today. Yeah, so drugs. I didn't talk about it, I just said drugs. Now, this is the slide on drugs. So if the heart rate persists below 60, I told you there are 3 things you check in circulation. Heart rate less than 100, less than 60, and less than 60. So this is the second 60, right? So you administer adrenaline. Now, adrenaline actually comes as 1 in 1,000. If you give it at that dose, you end the journey faster than it should be. It means you contributed to neonatal mortality. And Dr. Peter will send some pediatric policemen to arrest you. Now, this is what you do, you dilute it. You can get an insulin syringe, or if you are very careful enough with a 1 ml syringe. So 0.1 ml of the solution as you got it, diluted with 0.9 ml of sterile water or saline, you have made it up to 1 in 10,000. A human being. We are dealing with human beings, not veterinary, right? A human being should get 1 in 10,000, not 1 in 1,000. So this is it. This is all I've said. So that's the product. That is how it comes. And then you give at a dose of 0.1 to 0.3 ml per kg, right? Okay, so endotracheal intubation, just to make the work easy for the person handling the station as we will do. So the endotracheal tube comes in sizes. The one we have for the mannequin is size 2.5, as well for the baby that is less than 1 kg. Now for the baby who is between 1 and 2 is 3.0 and then 3.5. Everybody will ask, how deep do I intubate? So it is 6 plus the weight of the baby. So let's do something very quick. The baby weighs 1.5 kg. What is the depth of insertion? Tip to lip. Who can tell us quickly? The baby weighs 1.5 kg. What is the depth of insertion? Tip to lip? 7.5. That's good. So that's what we do. So you get that done at the hands-on session. Good. So this is the last slide, right? So post-resuscitation care. For the baby that did not require resuscitation, give the mother. When you do your airway and the baby peaks, you must check for breathing because the golden minute must be completed. You started ambu-backing and the baby picks up. You don't need to progress. The baby has recovered. You take to post-resuscitation care, right? Or you check baby's heart rate is less than 100, you've done Mr. Soper, you've adjusted all, it has come up, breathing, you go to post-resuscitation care. What are the aims? To optimize ventilation and circulatory function, to preserve organ tissue function, to maintain recommended plasma glucose level, and be sure we don't have hypothermia. So the care for the baby holistically begins after that, as fast as possible. So you want to support specific organs. It is strongly recommended that post-resuscitation, that every newborn baby with saturation less than 100 and less than 90% be giving oxygen. So if I people still giving oxygen when saturation is 92, well, if you look at the algorithm in your hands, there are time intervals where you would need to see. This baby is not yet 10 minutes, but for this one, post-resuscitation, less than 90, you give. Wow. So in the last 3 minutes that I have, summarily, neonatal resuscitation is a teamwork, right? True or false? Now, the golden minute is life for the newborn baby. You mess up with that golden minute, no, not this audience, right? So nobody plays with the first minutes of life. The neonatal resuscitation algorithm is easy to understand, but it's only mastered when you practice it. So we have 8 stations where we will master it. Mr. Super is your sure lifeline when chest fails to rise with ventilation. I leave you with this quote. Sometimes it is okay if all you did today was breathe. So take a deep breath and rest. So with the 2 minutes right? Or you check baby's heart adjusted, or you go to post-resuscitation care. What are the aims? To optimize ventilation and circulatory function, to preserve organ tissue function, to maintain recommended plasma glucose level, and be sure we don't have hypothermia. So the care for the baby holistically begins after that, as fast as possible. So you want to support specific organs. It is strongly recommended that post-resuscitation, that every newborn baby with saturation less than 100 and less than 90% be giving oxygen. So you find people still giving oxygen when saturation is 92. Well, if you look at the algorithm in your hands, there are time intervals where you would need to see. This baby is not yet 10 minutes, but for this one, post-resuscitation, less than 90, you give. Wow. So in the last 3 minutes that I have, summarily, neonatal resuscitation is a teamwork, right? True or false? Now, the golden minute is life for the newborn baby. You mess up with that golden minute, no, not this audience, right? So nobody plays with the first minutes of life. The neonatal resuscitation algorithm is easy to understand, but it's only mastered when you practice it. So we have 8 stations where we will master it. Mr. Sopa is your sure lifeline when chest fails to rise with ventilation. I leave you with this quote. Sometimes it is okay if all you did today was breathe. So take a deep breath and rest. So with the 2 minutes I have, because I was timing myself. No, you don't come and tell, I was timing myself. I have 2 minutes. So do we have any questions? Even though I have a lot of questions for you. Any questions? Okay. Okay. What?
Mode of administration of that adrenaline.
Okay, so adrenaline, we said it comes as 1 in 1,000. That's the formulation. So you get 0.1 mil, add with 0.9 mils of normal saline. So 0.1 to 0.3 mils per kg intravenous, or up to 0.5 mils per kg if you are giving intratracheal, right? So you push it very fast. You can repeat every 3 to 5 minutes, very, very fast, till at least up to 3 times till the baby picks up. I have a question here for this circulation. What do we do when the heart rate is less than 100 beats per minute? Good. So we said 100, 60, 60. So if it's less than 100, the slide on Mr. Soper where you go to troubleshoot to check that the mask is positioned well. You reposition the neck to be sure you are in neutral position. Those steps that I just went through. If the airway is not clear, you suction, you do that. After that, the heart rate peaks above 100, resuscitation ended, you go to post-resuscitation care. But if it drops further, goes below 60, that's where you start 1 and 2 and 3 and breathe. So, oh, okay, fine. That's all.